All right, so does the picture help? You see the real narrow pulmonary artery? So it's pulmonary stenosis. The right ventricle hypertrophies because it's struggling against that narrowed pulmonary artery. You're not going to have much blood flowing to the lungs coming from the right ventricle because it's so narrow. And then you have a hole between the right ventricle and left ventricle. So when the heart contracts, you're getting deoxygenated mixed with oxygenated blood going into the aorta. So that's 1, 2, 3, and then the large right ventricle is 4.
So many problems.
Yeah. So 4 problems. So blood has to go through the aorta to get to the ductus arteriosus to get to pulmonary circulation. Does that make sense?
Mm-hmm.
How are you going to get the blood to flow to the lungs if your pulmonary artery is all deformed and blood's not flowing through it? So what about the ductus arteriosus? Now you can put the blood in the aorta, send it back to the ductus arteriosus into the pulmonary circulation, and that way you can oxygenate the blood.
They're getting real special with that. So do they give them something to open it again?
To keep it open?
Yeah, to keep it open? Okay.
Yes.
That makes sense.
Very good. So the heart is shaped like a boot on X-ray. Why do you think that is?
Because it's at an angle?
At an angle?
Because of the muscle.
Yes. So
Okay.
the right side of the heart is enlarged, and that's what makes it look like a
Oh,
boot.
okay. That's what you're asking.
And then severity can vary from one child to the other. It depends on the narrowing of the pulmonary artery and the valve. Cyanosis will increase intermittently. It tells you that any increasing venous return to the heart results in a larger right to left shunt. So let me explain that a little bit. Because you've got the aorta accepting blood from both the right side of the heart and the right ventricle and the left ventricle, when you have more right ventricle deoxygenated blood, when they combine to go into the aorta, more of it is deoxygenated. If you have less blood flowing back to the heart, now you'll have a higher percentage of that oxygenated blood entering the aorta. What do you think? Can you imagine that? Is there a way to draw a picture of that?
It all depends on what side has more blood at that time. If
Yes.
it's coming more from the venous side, it'll be less, it'll be more deoxygenated blood. And if it's coming, if you have more blood from the left side, it'll be more oxygenated.
Yes. All right, so do you want to write that in your notes somehow?
Yeah.
How if you have more blood returning to the right side of the heart, and an example would be like when the baby cries, you know how you take a deep breath when you're crying? So that negative pressure in the thorax pulls more blood through the inferior superior vena cava back to the right side of the heart. So when these babies cry, they get really blue because there's a lot of blood coming into the right side of the heart, and there's more blood to get into the aorta that has been deoxygenated, or that is deoxygenated.
Oh, so the shunting occurs?
Yes.
Okay.
When they're not crying and you don't have that increase, you've got like an equal chance of oxygenated blood from the left ventricle getting into the aorta. So I don't know how you want to word that on your paper.
Basically, more blood on the right will be deoxygenated blood going through aorta, more blood on the left, more oxygenated.
Yes. Okay, so that made it really simple.
That was good. I like that one.
What did you write, Stacy? You want to write that? Does that
That
make
was
more
pretty
sense?
simple.
That
was.
makes so much sense, like in like 3 seconds.
More blood on the right, more deoxygenated blood in the aorta.
Yeah.
All right, so when the infant cries, again, the negative intrathoracic pressure, there's more negative intrathoracic pressure, and that's what pulls more blood flow back to the right heart. Feeding, like sucking, also causes negative intrathoracic pressure. Defecating, I would think opposite, but it's listed here as actually causing more blood to flow back to the right heart. So they, when they're crying, when they're feeding, when they're defecating, they become very cyanotic. And they're called TET spells, T-E-T spells, TET spells. So best way to treat it is decrease venous return back to the heart by pulling the knees up to the chest. And I guess the blood that's flowing back from the lower extremities, if you like pull the knees up to the chest and hold them tight, you've got less blood flow coming back to the right heart. If you administer 100% oxygen, that could help to vasodilate the pulmonary vessels. And morphine is a powerful vasodilator. So it's another way to prevent all of that blood from flowing back to the heart. It's by giving them morphine and dilate the venous bed, and that prevents all that blood from flowing back to the right heart. So does all of that fit? AV canal is a very common congenital heart defect. It's found in babies born with trisomy 21. And you have an extra chromosome. Your 23rd chromosome has an extra.
Oh, is that Down syndrome?
Yes.
Yeah.
Yeah, so trisomy 21 or Down syndrome. They have a high incidence of AV canal defect. There's incomplete development of the septa between both the atria and incomplete development of the septa between the ventricles. You get one AV valve, and that's it. So it's like the heart of a frog, where it's just all one chamber. I don't even know if a frog has all one chamber. I don't know why I said that.
How do you know that? That's good information. They really have only one chamber?
Now I'm going to have to look it up.
It came out so naturally.
I know. Like, I believed you. I
It's
trusted
not
you.
unbelievable.
I believe
Don't write it down. I need to look that one up. I must have heard that as an explanation, that it's just like a frog's heart, but I need to verify that that's true. So when you have a big hole between the atria, a big hole between the ventricles, you've got one large chamber. This allows blood to mix among any of the heart chambers. The defect has a scooped out appearance, and hence the term canal. All right, so let's look at a picture. So there's communication between the right atrium and the left atrium. There's communication between the right ventricle and left ventricle. There's only one valve between the atria and the ventricles. All right, so when the heart contracts, what is it like to do? Well, one thing that we know about pulmonary circulation is it's a very low resistance circulation. Remember the normal pulmonary artery pressures in an adult? It's like 2 dozen over 1 dozen, 24 over 12. It's normal pulmonary artery pressure. compare that to systemic blood pressure, 120 systolic over 80 diastolic. So much higher pressure in the going into the aorta versus going into pulmonary circulation. So if your blood, and you want to take the pathway of least resistance, where are you going to go? You're going to go into the aorta, or are you going to go into the pulmonary circulation where it's all kind of laid back and
Pulmonary circulation.
yeah. You're going to want to go into the pulmonary circulation. It's the pathway of least resistance. So can you see how that's going to cause an engorgement of blood going to the pulmonary vessels?
Yes.
All right, so they quickly, like within a couple weeks of life, develop severe pulmonary hypertension from so much blood being forced into the pulmonary vessels. And when you've got blood that's mixing, like oxygenated and deoxygenated blood is mixing and going into the aorta, is that going to cause a cyanotic or acyanotic defect? It's going to be cyanotic. You have the mixing of the two bloods and they both go into the aorta. So initially it starts out as a left to right shunt where a lot more blood goes into the pulmonary artery. And to keep blood flow diminished from going into the pulmonary artery, it's best to keep the infant hypoxic. Remember the hypoxic pulmonary vasoconstriction? So if you constrict the pulmonary vessels, now that's going to prevent so much blood from flowing into the pulmonary circulation. So it says supplemental oxygen may be given, but use judiciously to minimize pulmonary vascular dilation. If SATs are kept low, like less than 90%, you're going to constrict the pulmonary vessels and now kind of protect them from getting too much blood flow. And I learned this the hard way because I was working in Peds ICU at Joe DiMaggio. Okay, it's been over 10 years, okay, guys. And you know, I was taking care of a baby and giving a nebulizer treatment, and the nurse comes from next door. We just got an admission. Can you please put a 1 liter nasal cannula on the baby next door? And I did. And I shouldn't have listened because it was a baby with AV Canal. And when I guess the intensivist came over to see the baby, and the nurse said, "Who put oxygen on this baby?" And the nurse pointed at me. The intensivist comes over to me and chews me up and down. Do you have any idea how you're worsening this baby by doing what you just did? Boy, did I learned my lesson. So the reason that putting oxygen on the baby was bad is it dilated the pulmonary vessels. There was too much blood flowing into the pulmonary vessels and causing pulmonary hypertension.
She set you up.
And threw you under the bus.
Yeah.
I'm gonna pray for you.
Yeah, so there was a lot of lessons to learn there.
So in that case, did you go down to your point, like 0.25 liters a minute? Like, did you go down to the lowest? Or what'd you do?
I should have asked what the diagnosis is. And once I heard AV Canal, then I should have looked at the O2 sat, and if it was lower than like 85, then just titrate the oxygen to maybe get it up to 88 or 90%.
Okay.
That's what I should have done. Life is a learning experience, right?
Absolutely.
I like to share everything I do wrong with you guys, so you know what to do once you're working in the hospital. All right, we already talked about is trisomy 21, Down syndrome, and that's all I have on that. So keep SATs less than 90 to reduce the blood flow to the pulmonary vessels.
So it'll fix itself, or it has to, they have to have surgery?
Yeah, they have to have, I think 2 or 3 surgeries.
Oh no.
They don't do it right away. They usually wait a few weeks or a few months. I just remember the families coming back in, like, oh, this is the second one, they're gonna reverse whatever they did, or,
Wow.
yeah, so it's more than one surgery to correct it. All right, so it's 2 o'clock. How many do we have left?
2 pages? Not much.
It's like,
Yeah, 4.
Should we go through the last 4, or do you feel overwhelmed, and we'll do it next time?
Can't give us that decision.
What have we got coming up?
you were right about the frog's heart.
Was right about what?
The frog's heart.
He looked up for you.
Oh, no kidding!
What? You
So
looked
a
it up?
frog has just one chamber?
Well, it has like a atrium and a ventricle right in it.
Ah, okay. So I can continue to, you can hear it to a frog's heart?
No frog heart.
It sounded right.
It came out too easy.
Yeah, it must have been true. You're so short.
See. What was I say? See again.
Yeah, next week is, it's better to do it now, guys.
Okay.
I need to keep you for a few more minutes. Only because we have a guest speaker coming next week, and then we need to talk about nitric oxide and ECMO. And that's enough to tax your brain beyond what you ever imagined possible anyway. So let me just finish this up. Okay, so hypoplastic left heart syndrome. Hypoplastic means it just didn't develop. So you've got a heart that doesn't have a left ventricle. Does it show the picture? So hypoplastic left heart. The left ventricle didn't develop.
Wow. That's a huge difference.
There's also mitral valve stenosis, so the mitral valve didn't develop. Hypoplastic left ventricle, the aorta is narrowed, and the aorta is also affected, coarctation of the aorta. All right, so blood goes into the right heart, great. Flows to the pulmonary vessels, great. Comes back from the pulmonary vessels to go into the left atrium, and there's a block. So, can you imagine how everything is going to back up in the system? It says to maintain fetal circulation and keep the patient hypoxemic, keep the O2s really low. Again, pulmonary hypertension, we want as little as possible to have blood flowing to the lungs and going back to the left heart. Patent ductus arteriosus will help to deliver blood flow to the aorta. So that would be the best way to get blood anywhere, because if it goes over to the left side of the heart, it's not going to leave. So it's best for it to cross over from the pulmonary artery into the aorta through the ductus arteriosus. Can you imagine if that ductus arteriosus closes? There's a very high mortality rate with this anomaly because of that. If for any reason that ductus closes, the baby dies shortly after. So when it's diagnosed, they immediately will put a hole in the atria, between the right atrium and the left atrium, so the foraminal valve. They put a catheter in there, pull it through, and somehow or other that just creates a hole. So now when blood flows back to the left atrium, it'll go through the hole and back over to the right atrium. So ASD helps to relieve high pressure in the left atrium. Mentions keeping SATs 80 to 85%, and in order to keep FiO2s lower than 21%, we've talked about adding nitrogen to the circuit. Here it talks about giving additional carbon dioxide into the ventilator circuit, because when you have acidosis, that also causes pulmonary vasoconstriction. Do you get the connection? If If you constrict the pulmonary vessels, you've got less blood flowing over to the left heart. Do you want to add that to your notes, or is that kind of like it belongs together?
Can you repeat that again?
Yeah, so you're constricting the pulmonary vessels to prevent blood flow to the lungs and then back to the left heart.
Does keeping or reducing the amount of FiO2 the baby's receiving affect other organ development, like having less than 21%?
You would think so. When the babies are born at 40-week gestation, yeah, you would think that the cells are now ready to have SATs of 90% and higher. Babies that are born prematurely, though, they're used to being in utero with a saturation of 70%, and their PO2s are about 30, and that's normal tissue development. Okay, transposition of the great arteries. The major arteries are reversed. So you take the pulmonary artery off and you stick it on the left ventricle. You take the aorta off and you stick it on the right ventricle. Everything's reversed. So what does that do? So you've got blood flowing from the right ventricle. It goes into systemic circulation, comes back to the right atrium, goes into the right ventricle, goes to systemic circulation, and it's just one complete separate circulation.
What? And it's not connected to the left side at all.
Right, and then the left side, blood goes into the pulmonary artery, to the lungs, and comes back to the left atrium, left ventricle, pulmonary artery, and that becomes a completely separate circulation.
But with the PDA?
Yeah,
That
so
would
can you
help.
see how important that PDA is
Yeah.
for blood to go from, which way will it want to go?
It'll go from, well, because it'll be well, it depends what the pressures are. Because they're both pretty
Well,
high.
you get a little bit in the aorta.
It
But
just-
the pulmonary pressures will still be the same, right?
Wouldn't
Pulmonary
they,
pressure should stay the same?
that means that the aorta would come down into the pulmonary artery, right? If they stay the same.
Yeah, I see an arrow going both ways.
Yeah.
So you only-
Yeah.
Are you
It's gonna be
getting
complicated.
much oxygen in systemic circulation?
Not much. Not much.
So it's definitely cyanotic.
The only blood flow you're going to get is whatever makes through the ductus arteriosus.
So the blood in the other side is just going to the lungs, picking up oxygen, bringing it back, going to the lungs, and dropping off at the same place.
Yep.
Yes.
Okay.
So would the aorta have to like cause pulmonary hypertension for the to then reverse to be able to like bring it to the other side?
So would we want pulmonary hypertension?
So that it can cross over to the aorta? Because
Oh. So we have this beautifully oxygenated blood
that we need to
in
get
the,
to.
in the aorta.
I mean,
no. No,
it's
it's not
the
in the
pulmonary
aorta.
artery.
It's in the pulmonary artery. And we want to get it to the aorta. So I guess it would be best to have this pressure higher
Mm-hmm.
to get that oxygenated blood into the aorta.
Yeah, that's what my thought process is. I don't know if I'm right.
Yeah, this one boggles my mind.
Yeah, it's boggling mind. I actually like it though.
I guess what the test question only asks for you to describe it or name it. It doesn't ask you how the blood should flow or anything like that. So as long as you remember that the two circulations are completely separate, and if you remember that the ductus arteriosus is the only communication between the two circulations, that's it.
Okay. That's all we gotta know.
Yes.
I had a baby who had this.
Oh, you did?
Yeah, he just had surgery to switch it.
Immediately after birth, or?
I don't know if it was immediate, but he was only a couple days old, so maybe after a day or so.
So they probably stabilized him. Did you notice anything different being done, like lots of prostaglandins, for sure?
If they did, I didn't notice it. Because I didn't know what it was, so I wasn't really looking.
Oh, I see. All right, so that's transposition of the great vessels.
Transposition.
Next is total anomalous pulmonary venous return. TAPVR. So when the blood comes back to the pulmonary vein after going to the lungs, picking up oxygen, and then the blood's supposed to flow back to the left atrium, somehow it flows back somewhere else in the body.
What? What? I'm confused.
So let's look at a picture.
Okay.
Wow.
Oh, so this is just special.
This is special, yes.
That's all it is.
So blood goes into the pulmonary circulation, everything's fine. Blood's coming over to the left atrium, but there's no connection.
Wow.
Instead, the pulmonary veins are connected to, it looks like the superior vena cava here.
Wow. So that's oxygenated blood going.
To the superior vena cava.
Wow. And wow.
So how do we get some blood into the left side of the heart?
I guess as soon as it goes. No, wait. We need a ductus arteriosus for this one, because nothing is in contact with the left atrium and left ventricle, right?
Right.
So we need the ductus arteriosus to make that connection.
A ductus arteriosus, okay.
Because there's
And?
no in the foraminal valley.
Yes, very good.
Good job.
So foraminal valve is very important with this. It shows a really big right atrium. Can you imagine? You've got blood from the lungs coming here, you've got blood, deoxygenated blood coming, everything's going into the right atrium. Everybody showed up for dinner. Now what do you do with it all? So you need a hole so that some of it can go over here into the left atrium. All right, so we're all set on total anomalous pulmonary venous return?
Mm-hmm.
That one. That's cute.
Okay, that one. You have to remember the letters or something for the test, because it's a fill-in. Like it gives you a description of the heart anomaly, and then you have to write in what it is.
Spelling counts too.
Spelling counts.
Really?
Yeah.
So we can't say TAPVR?
No, so if you said like tuna fish sandwich or something, no, you don't get credit for it.
What about acronyms?
TAPR.
Like PDA,
Total anomalous pulmonary venous
Will you
return.
accept that?
At least you gave us the answer.
No, you gotta write it out.
That's fine, because you just gave us the answer, so I'm happy.
Okay.
Sounds good.
All right, and then truncus, arteriosus, your aorta is like a big, huge tree trunk. An overriding aorta receives blood from both ventricles through a ventricular septal defect. Isn't this like an alien heart?
Very, very alien.
So you've got blood coming from the right ventricle going into the aorta. Blood from the left ventricle goes into the aorta. And then once it gets there, it splits off. Some of it will go to the lungs, some of it will just go to the rest of the body.
So it's just one connect. So the pulmonary artery and the aorta are fused together.
Yes.
Okay.
Yeah.
That's interesting.
Yeah, so the pulmonary artery and the aorta are fused together as one vessel. Okay with that? Oh, that was it.
Huh?
That wasn't too bad. Yes?
Yes, proud of.
Goodbye. Goodbye. Little family. At least you're gonna remember. Oh, that's true. That's true.
Yeah.